Thank you for me tonight for joining us for the webinar. You know, the topic, the importance of your light curing and how it plays such a big role in our practices is I really think it's one of the most underappreciated topics that we could discuss tonight, and really plays a huge role in our practices. So with all bad jokes aside, I'd like to shed some light on what we can do in our practices to ensure good patient outcomes when we use our curing lights in our dental offices. The disclosure and disclaimer of Blue Light Analytics has assisted in allowing me to be with you tonight to present this webinar. Curing lights, you know, they come in all shapes and sizes. You can probably see a curing light there that you've either used in your office or are currently using. Matter of fact, you might even see something like this that might currently be in that closet or cupboard in your office that at one point was your daily workhorse and now has been retired, and you've picked up something new and unique to use over the last few years. The question for me, though, is what goes on with the lights? And if we think about our practices, our lights are such an important part of what we do at the chair every day. I think right up there with our dental handpieces. We use them every day, day in and day out. And yet the question is, are we taking them for granted? Can we really just pick up that light, turn it on, and expect it to work? And how is it going to work when it works? So what are our topics to cover in the webinar? I'd like to take a little bit of time and kind of enhance our knowledge base of the clinical importance of proper light curing. Let's evaluate the key components to establish a really good and efficient light curing technique with your LED lights for you and your staff that you can incorporate in the practice. And learn about some new technology to accurately determine and monitor how your lights interact with the composites that you use in your office every day. Some bottom line basics for selection and use of your LED curing lights, and then kind of putting all this information together and making it into a practical and positive package that you can use in your practice when you go to work tomorrow morning or as we go through the rest of the week. Truth is reality. 1990, almost the vast majority of the dentists chose amalgam as their primary intercoronal posterior restoration, and yet advance that clock 20 years later, 2010, the pendulum had swung the other way, and direct composite restorations exceeded amalgam in the posterior portion of the mouth by more than 2 to 1. 1/3 of the dentists don't even use amalgam anymore, and those that do report a steady decline. And according to 2013 data, dentists currently place about 22 million dental composites in both the anterior and the posterior per year. And I'd probably say if you wanted to look at that and extrapolate that to 2018 or 2019, we might be another 10 or 20% higher than that at this point. They really do dominate our direct restoratives in the mouth today. Why do we like composite? Well, I think it's conservative in nature because it has the flexibility to restore only what's missing. You can use it as a long-term restorative if you truly believe in its longevity, or even as a transitional restoration if you're waiting until someone can afford to do full coverage crown on a tooth. And it's probably the less costly or least costly to the patient than any other tooth-colored material available to them. How long do composites last? That's always a question that I get asked, and I'm sure you get asked that as well by your patients. And there's studies definitely out there studying the longevity of dental composites. This one, interestingly enough, looked at dental composites and amalgams and other restoratives like glass ionomers in England and Wales over a more than 10-year period of time, tracked over 500,000 restorations. And it really did track basically composites that were used primarily in the class 3 and the class 5 region. And what they found in those areas, that the time to reintervention, or when something else had to be done, the composite repaired or replaced, was quite shocking. That the longevity of these composites, only 11% after 1 year, and after 23% after 2 years, needed some redoing or reworking. Now, that may have nothing to do with the composite, it may even have nothing to do with the technique that we use. It may be more of an indication of the extent of the restoration rather than a failure of the restoration. But let's talk a little bit about posterior composites. How long do they last? Several studies have given us a mean longevity of 6 years. Primary reason for replacement is secondary caries and bulk fracture of the resin. But we really need to pause and understand the factors that affect this longevity, such as the patient themselves. How do they function on a tooth? Do they have a parafunctional habit? Things like that. The clinician, the skill level of the clinician, and how long have they been doing composites? the difficulty of the procedure itself, the isolation of the bonding site, the size and location of that restoration, the polymerization shrinkage that occurs when that light is turned on, and the energy needed from the light curing unit to really cure the resin properly, and many, many more. I think the takeaway from this is that some of these factors are really hard for us to measure, yet the amount of energy required to cure a composite and the amount of energy that dentists can deliver can certainly be quantified. A little history, because if we don't know where we're going, we're going to end up somewhere else. So a little history on light curing. The placement of direct composite resin, we've been using it in the posterior portion of the mouth for over 50 years. And since the introduction of light curable composites in the late 70s, the incremental layering technique has really been considered a necessity for a variety of reasons. And besides the layering techniques, we've employed several light curing philosophies, such as ramping, pulsing, soft start, things like that. And they've been employed to counteract the inherent issues with polymerization shrinkage and shrinkage stress. The layering concept of composites, the traditional horizontal layering technique, really has revolved around placing 2mm increments and curing each layer from the occlusal. And this has been used by the profession for really two major reasons. Number one, the materials themselves, until the last several years, have had a limited curing depth, and that's prevented us from using them in more extensive increments that we could polymerize properly. And then using smaller increments was also necessary to potentially involved in an effort to control the shrinkage and the shrinkage stress issues due to polymerization reactions. And yet, incremental layering isn't always what it's cracked up to be, because there could be some disadvantages of using incremental layering, such as the probability of creating gaps between each layer and air bubbles and spaces, the potential for a cohesive failure between each increment placed, the light curing of each layer, and the polymerization shrinkage and stress created by each of those individual layers being placed as well. How about just the extended time at the chair necessary to place the composite in those various layers, 2, 3, 4, 5, 6 layers sometimes. And then the difficulty placing the resin in conservative preparations. Again, with the more minimally invasive preparations we're doing today and the conservative preparations, getting a composite built up in incremental layers in a small preparation is quite challenging. And maybe we need to look at some materials that are more of a flowable type material that we can place in a larger increment. The light curing market itself is really dominated by the LED lights. This 2015 data shows LEDs making up about 97% of the light curing market. And they've clearly taken over. Matter of fact, I again venture to say if we looked at today's data, 2019, 2018 type of data, the LEDs lights are probably in the 99+% range in the market. And yet LED lights aren't perfect. They're just as susceptible to degradation as the halogens were, but we really still need to monitor them. And we don't talk a lot about how we monitor. We will do that tonight a little bit. But is an LED light, and an LED light? Are all LED lights equal? What we can't see can hurt us sometimes, and this is an interesting study of over 900 curing lights in over 400 dental offices. And they found that 73% of the test results identify the need for changes in the clinical protocol of that dental office. 30% of the lights delivered less than half the energy dose necessary for the selected composite material. And 43% of the offices used extended curing times, obviously to try and ensure an adequate cure, but unknowingly, because of those extended curing times weren't monitored, they risked the increased heat damage that could cause some pulpal damage and or post-op sensitivity for the patient. And then curing times used by the clinician range from 30 to 90 seconds, regardless of the material used. So there really wasn't a roadmap for these dental offices to know where to go. How much should I cure the material I'm using, for how long, and with how much energy? So light curing education needs to be advanced, because really light curing is not simply like picking up your remote control, clicking it, and turning it on and it works. Light curing is much more intense and involved than that. And this particular study that was published in JADA in 2014 found that the current light training provided to dentists and dental students simply were just not adequate at all. And this is an interesting kind of picture here, you look at these, I think it's kind of a bad Etch-a-Sketch. But basically, this study took a patient simulator model that was had a controlled preparation and was light cured by both dentists and dental students, first without training and then later on with training of proper light curing skills. But this interesting, I'll call it Etch-a-Sketch, shows the irregularity of the light energy produced when the curing light was used by the dentist and the dental students without any kind of education at all. Once educated, though, you could see how the light energy remained much more level and was not all over the board. So what are the takeaways from this particular study? I think are very, very important for us to use clinically at the chair. We want to make sure that we always wear proper eye protection, and this is a no-brainer. We can risk a lot of retinal damages and things that we can't even calculate at the chair when we're using this light numerous times a day, day after day, week after week, year after year, chair side, as well as for our auxiliaries too. We also got to look at what we're doing. Part of why this study was very important to us is it showed that if you're not watching exactly where you're placing the light, you have a tendency to drift off of that tooth or off of the restoration, and that can have a huge impact on the bottom line of the results of how that restoration functions and the longevity of that restoration. And you want to be able to stabilize the light in close proximity to the restoration. Again, getting the light as close to the restoration as you can and maintaining it there are two of the key fundamentals that we can control at the chair. When we talk about posterior composites and pairing them up with our light curing skills, Class 2, it really dominates the market. 45% of the composites that we do in our dental offices are Class 2. And if you look at the 22% that are Class 1 composites, really 2/3 of the composites that we do in our offices revolve around the posterior portion of the mouth. Much trickier, much harder to get the light source exactly where we need to. So we really have to work hard to make these composites work. Today's requirements for a composite are amazingly great. I mean, I think the list should be exhaustive. The materials we have today are tremendous compared to where we were 20 or 30 years ago. If we can use a composite that's universal and use it throughout the mouth, both anterior and posterior, that's tremendous. I think that would be a great boon to our practices from a standpoint of economics and cost savings. We want to make sure it has great abrasion, wear resistance, flexural strength, compressive strength, physical properties. High radial opacity is very, very important for us, especially in the posterior region of the mouth. And then we want to be able to finish this composite, polish it, and then we'd love that finish to be maintained over a long period of time, recall after recall, year after year, both in the anterior and the posterior. A composite with great aesthetics. Patients, I think, are becoming very, very attuned to not just putting a white filling in the tooth, but having something that matches very closely. Of course, this is important to us in the anterior, but in the posterior as well. We want to make sure it blends in with the surrounding tooth structure and almost becomes invisible to the patient if we can. User-friendly handling properties. How do I get it from the package into the mouth? And I think, again, the manufacturers have done a marvelous job for us with some of the flowable resins today, some of the composite compules and the guns that we have to create an avenue for getting that composite from the package into the patient's restoration. We want to have low shrinkage and low stress on the composite, and many of those, especially in the posterior region, have addressed that with their products. Curing with multiple energy sources. Again, if you're using an LED light, what kind of LED light are we using? What are the chips in it? We're going to talk about that in more detail in a minute. And then compatible with multiple bonding systems. Depending, again, on whose bonding system you're using, can I use someone else's composite with it, and is it going to be compatible? And bottom line on all of that is, are there clear instructions for use? How do I use the composite? How do I use my curing light? How do I use them together? That's an interesting question, and we're going to explore that as well, because it's not always as clear as we'd like it to be. We have a lot of challenges when we really look at posterior composites specifically. A 2011 survey showed that 63% of the dental schools really were not teaching amalgam as the preferred restorative material any longer, that composites have really taken over. And I would venture to say that's absolutely true really throughout the United States as well as internationally. But composites are not easy to do, and especially in the posterior. A lot of hurdles for us. I mean, just the preparation itself. What do we use to prepare the tooth? How do we isolate that preparation? And I'm not talking about using a rubber dam. If we're using a rubber dam on a daily basis, you know, I tip my cap to you, that's fantastic. But good isolation with cotton roll, isolite, different things like that to try and keep the field dry, but also proper isolation by picking out the right matrix and placing that matrix in the right way. So do you get the maximum benefit of the matrix for isolation, as well as maximum benefit for the shape and form of the tooth itself, the restoration that you're creating with the composite. Then we got to worry about the whole bonding cycle. What's going on with that? Am I going to use a total etch approach, a selective etch approach, or a self-etch approach? And what are the advantages of those? And what are the disadvantages of those to me as a clinician? And then the adhesive. One thing I can say that we can't stress enough as a profession is that we really need to read the directions of these dentin enamel adhesives. They are so varied between the number of layers that you place on them, the time that you leave each layer on, things like how thin you thin the adhesive out with the air, and is it soft air, is it firm air, is it dabbing off with a cotton pellet or a little sponge? Important things to us to try and get the best adhesive layer on that dentin enamel that we can. And then the instructions say just turn the light on, whether it's 10 seconds, 20 seconds. You know, again, a very vague direction for us, and this is something that we really have to concentrate on in our composites. And then the filling itself, the material, the composite selection. Am I going to fill it in an incremental fashion? Am I going to fill it in multiple types of layers? Or am I going to simply use a bulk fill approach or semi-bulk fill approach? And that will really dictate what we're going to pick for our composite. And then again, the instructions will say pick up the light and cure it a specific number of seconds, but not necessarily giving us a lot of direction on that. And then of course, shaping and polishing our composites can take a lot of time. And how do we streamline, you know, that? All of those techniques, you know, create a challenge for us at the chair to even fill the tooth with a posterior composite. But, you know, layering versus bulk fill doesn't have to be that challenging for us. With today's materials, many of those original challenges we've had with posterior composite resins have been solved. And if not solved, attenuated or somewhat satisfied. But changing our behavior to understand that we can create great restorations with large increment composites utilizing the light sources we have today are really out there. And this is a great literature search by Mark Patel a few years ago, published in Compendium. To date, the literature has not shown conclusively that incremental layering definitely helps reduce the effects of shrinkage stress versus bulk fill placement. So really, between good curing lights today, great techniques, and great materials, we have the ability to utilize and do things that we couldn't do 5 or 10 years ago. But the bulk fill concepts and using our curing lights, really we have to pay attention to what we're doing. Advanced science behind the fillers and the monomers and the photo initiators in these composites now allow us to place those larger 4 and 5 millimeter increments. It's important for us to analyze that technology that creates the changes in the resin, and we really have to see if the performance that they're telling us in vitro carries over to our clinical situations, and do we see the results that they're telling us we can get. But really, most importantly, the attention to detail with the placement of any composite resin, regardless of the approach you pick, is paramount to successful patient outcomes. Composite resin, from the bulk fill standpoint, I think come in a couple of different shapes and sizes. Flowable bulk fill composite resins and conventional body paste bulk composite resins. And the flowables come in two shapes or sizes as well. You have an initial, one that we would use as an initial layer or underlayment, and that would require a 2 millimeter top cap of a traditional body composite. And then you have flowable bulk fill composites that can be used in toto to fill up the entire 4 to 5 millimeter increment with one material and does not need a top capping layer. The conventional body bulk fill composites can be used as a single 4 to 5 millimeter increment. And there's even one that's a single increment that can be modified with sonic activation. But how do they really stack up? When we start using them in our chair and our offices, how do they stack up to our patients? That's what we want to know. And again, studies have shown both marginal integrity and micro leakage, no difference between the marginal integrity and micro leakage between the bulk fill and conventional resin composite, bulk fill composite. So We really have some materials that are great. We've got some lights that are great. We just have to learn how to use them well together. And this was a great study by the ADA where they really took the next step on some of the studies and looked at an in-depth at 12 different composites based on their physical properties. Looked at things like depth of cure, volumetric shrinkage, flexural strength, water absorption, shade and color stability, and radio opacity. And they compared these 12 composites, 2 basic incremental paste type composites, 6 bulk fill body or paste type composites, and 4 flowable composites that are bulk fill in nature as well, and just compared them, toe to toe, head to head. And what did they find were the results on this? They came back with their conclusion that the laboratory performance of these bulk fill composites was comparable or better than the traditional multi-increment fill resins that we've been using. So the materials are definitely standing up to this bulk fill and semi-bulk fill technique. But what really happens when you turn that light on? And maybe the question we really should ask ourselves, and what do you think you should, what should you think about before you do it? That's really very interesting. Because once we turn the light on with these composites, whether it's incremental or bulk fill technique, these composites are going to shrink. And the shrinkage of the composite is a volumetric change, and it places stress within the resin material and at the bond interface during polymerization. The importance of managing this stress is very important to us clinically because all sorts of bad things can happen if we create too much shrinkage stress within that composite restoration and within that preparation that we've made. And things like debonding and marginal staining, micro leakage, secondary decay, enamel microcracks, cuspal fracture, debondings, even within the restoration itself. And of course, the dreaded post-op sensitivity, getting the phone call for the patient saying that, that restoration that you just placed the other day, they can't bite on it, it's sensitive to cold. No one wants those kind of phone calls from a patient. So we want to do everything we can to manage these issues that come up. And polymerization shrinkage in general, the shrinkage is a volumetric change and all composites are going to shrink. Now, some of them are shrinking less than 1% now, but there still is a volumetric change. And the stress created during this phase where the composite goes from a gel phase to a final hard phase, it's a complex interaction of cavity geometry, reaction kinetics, volumetric shrinkage, the degree of conversion of the material, and the elastic properties of the composite itself. The bulk fill composites generally have a higher filler content, which is an inorganic rocks basically in the composite, and they don't react and they maintain a constant volumetric dimension. And the bulk fill composites through various studies have shown less shrinkage, less polymerization stress, and less cuspal deflection than the conventional composites. And both materials have presented similar marginal integrity, flexural strength, and fractural strength as well. But when we look at combining this with lights, we have to look at the data there too. What does the science tell us about what happens when we turn on the light? And this was first published in the Journal of Adhesive Dentistry in 2014. It was a consensus statement from a symposium held on light curing in Halifax, Nova Scotia, a 2-day symposium, and key researchers, as well as support and participation of numerous dental manufacturers, were present at the meeting. I think it serves as an excellent guideline for us in the selection, use, and safety and maintenance of our dental curing lights. The gist of this paper were also kind of republished in a different article that appeared in Dentistry Today in 2014, where the core list of variables, the core checklist of variables was introduced to us as to what we might look for in a dental curing light. And the core checklist, as patterned by Richard Price, would tell us that C stands for curing light characteristics, things like output, beam profile, collimation. That O stands for operator technique, which means placement and orientation of the light tip. R, restoration characteristics, the location, size, and depth of the prep. And then E, for the energy requirements, material selection, such as am I using a light or a dark shade, a body versus flowable, and the spectral emission needed to match the photo initiators in the materials that I'm using. The consequences of improper light curing, Not a good thing, as you can only imagine. Insufficient polymerization could lead to things like inflammatory response from the pulp, lower bond strengths, micro leakage, sensitivity, recurrent decay, none of which, again, make for a good longevity of the restoration, nor keeping things from happening to our patients where we're going to get a phone call later on. And yet, when we look at things like the instructions that come in the box when we open up a composite material, there can be all over the board. I mean, some instructions might provide, a clear range of intensity that we need from our light source, 400 to 1,000 milliwatts per centimeter squared, 1,000 to 2,000 milliwatts per centimeter squared, and a corresponding time with a maximum layer increment. There might be some shades that get grouped together, and they might even have different instructions, such as the example on the left. Now, there they've taken body, enamel, and translucent shades and kind of put them in one category, and then lumped dentin and the darker body shades, an A6 and a B5, and given certain parameters or certain guidelines for the increment that's properly cured with a sufficient light source for a particular period of time. On the right side, the information provided in those kind of instructions might include the results from the ISO test 4049 on the depth of cure, but this instruction kind of table, so to speak, might be interpreted different by users because there's no distinct light curing instruction. It's just a data table. So again, are the instructions always clear? Not necessarily so. That's why you need to take these kind of things to heart in creating your own pathway to success. The energy required to cure a composite, every brand and shade of composite has a signature level of energy needed to polymerize that resin. The main photoinitiator is camphorquinone, CQ, which has a peak range in the 450 to 470 nanometer range, which is considered the blue range. There are other photoinitiators, newer ones out on the market over the last decade, that have a different wavelength outside of the blue range. And these are used in some shades of composite like bleach composites and certain adhesives. Now, because their wavelength is outside the blue spectrum, potentially with certain blue LED lights, they may not properly cure. So modified LEDs have been made, or modified chipsets were added to some of our lights to create a broader spectrum light, which are also known as dual wave or polywave lights. Studies also confirm when we try and cure composites that opaque shades and darker shades do require increased curing times compared to more translucent or lighter shades like a B1 or an A1. Evidence also shows that some flowables and microfill composites may require additional curing times to properly polymerize. It's always best, though, to refer to your manufacturer's recommended curing times and output suggestions prior to using all your composites. So again, reading the directions and the instructions, believe it or not, are quite important to us. So taking a look at Price's core checklist for us, let's go back and review what some of these terms mean. Beam profile, very interesting term. It's defined as the mapping of the energy transmission at the surface of the tip of the light. And it's the effective part of the beam that gets the energy into our restoration. So if you look at the beam profile here on the left side, this is a great beam profile where the energy is very universally displaced throughout the entire size of the light tip. But when you take a look at this one, or this one, or this one, you see that the key energy sources are right here, or right here, or right here. And the areas out here, or around here, are not receiving the maximum energy and may be actually being unintentionally undercured. So if you have a light beam profile on your light that's got this kind of a pattern, you're going to have to overlap and make multiple passes in order to properly cure that restoration. The question is, do you know that from your light that you're using right now? And then, of course, things like beam profile and spectrum. Not only can lights vary in their distribution of their intensity, for broad spectrum lights in particular, they can also vary in the type of light. Broad spectrum LED lights have some chips that produce blue and some chips that produce violet. Now, this particular light happens to have 3 separate LEDs, and yet all 3 have non-uniform spectral emission and non-uniform radiant power, as you can see by what's coming out of those 3 LEDs. This can be a concern because you're curing and you assume that the light energy and the light spectrum emitted are uniform over the entire surface of the tip. So you may inadvertently be missing some of the areas in that preparation curing your resin. Beam profile and spectrum play another role. These happen to be the actual chips, broad spectrum chips. And again, the clinical significance of understanding the beam profile and the various chips that are in our LED and the various LEDs themselves, the violets and the blues, is that since the rate and extent of polymerization of photoactivated materials is dependent on delivering the energy at specific wavelengths, this non-uniform distribution may affect the resulting properties of some photocured resins and their potential for long-term clinical success. So numerous studies have been looking at this and support the fact that this can be a problem for us. How about beam collimation? Another on our checklist, beam collimation. I want you to think of a garden hose, and you want to turn that garden hose on with as strong a stream of water as you can because you're trying to get the mud off of the tires of your truck or your car. You don't want to have a soft, more of a gentle rain type of water spray coming out of your hose. And the collimated beam of light would be like that heavy garden hose. You want that column of light to maintain the same energy, intensity, and wavelength all the way down the beam itself as far as possible. As you get further and further away from the tip, you're going to lose some of that energy as it gets more dispersed in a non-collimated beam. The position of the light source, something that we can control, but it varies depending on a lot of factors. The angle of the tip and the angle of the light itself, how it's designed. Is it a gun? Is it a lollipop? Is it kind of an angle to the tip itself? The size of the tip and the diameter of the tip. Potentially, I'd like to say 10 millimeters is kind of the sweet spot. That's a nice size tip to have on the end of any light. Also depends on which tooth is being restored. Are we working on tooth number 6 or are we working on an MOD on number 15? And then of course my favorite, the ability of the patient to open. As we all know, it's a long day of dentistry sometimes, and that's the certain time when that patient can, you're working on number 15 and you ask them to open their mouth and they can't open very wide, and you ask them to, no, we really need to open a little bit more, and they just can't do it. And it's going to be a long restoration and a challenge to try and get this cured properly. All of these can lead to inadequate curing of the restoration and ultimately a decrease in the longevity, the potential for post-op sensitivity, recurrent decay, and all sorts of things that we don't want to have happen. So how do we measure a light intensity? Measured with power, milliwatts, times the area, the surface tip of the guide, and it's translated into irradiance, milliwatts per centimeter squared. According to the literature, light curing lights should have a minimum of 600, 1,000 milliwatts per centimeter squared. My preference is to set 1,000 milliwatts per centimeter squared as the threshold. LEDs, which measure over 2,000 milliwatts, can generate some heat. We're going to talk about that more in a little bit. And the most common way to measure this is using a dental radiometer, specific for the light type, i.e. you want to have a dental radiometer specific for LEDs. There are radiometers specific for the older halogen lights too. Now, studies have shown these radiometers maybe to be a little bit unreliable, and yet they still remain the simplest, most effective way for us to monitor our lights on a regular basis. And again, there can be variation in output with that same light brand over time, but they can drift away. The LEDs can degrade just like the halogens did over time. So keeping a log of your output on a weekly basis, a monthly basis, I mean, checking your lights is very important. We check our lights on a weekly basis. It doesn't take very long, and you would be surprised that a light that started out at 12 or 1,300 milliwatts per centimeter squared 6 months or 2 years later is now at 1,000. Is that affecting your clinical performance? Well, we're going to talk about that in a little bit. And radiometers continue to advance more and more, and we're going to really hit that in a couple of minutes. Material instructions though, knowing the light output, how to measure my light. This is the same light used with 4 different radiometers, giving us 4 different readings. Isn't that interesting? And yet, the manufacturer stated that the irradiance was 1,500 milliwatts per centimeter squared, and yet, when tested with a different kind of radiometer, a specific clinical or research type radiometer, the actual output was 1120. And lateral variability, how you hold the light tip and how it varies by as little as 1 millimeter can make a big difference in the output of the energy, as well as several publications continue to show that radiometers are accurate, but some of the radiometers, the size of the aperture is not the same size as the aperture of the light itself. So really they should correspond to be the same size, the light tip and the aperture in the radiometer, to really give you the most accurate reading. And none of the radiometers are up to ISO standards. And so again, we are using the best data that we have at the chair right now if we're using a radiometer at chairside until we talk about new technology. So how long should I cure my composite? I think the bottom line there is you want to always consult the manufacturer's recommendations for the material itself, because the light type that you use will play a role in this. The light performance, what's the intensity of that light, what's the beam collimation, the size of that tip, and the beam profile itself. The material, that plays a role, of course. What shade am I using? An A1, a B1, or a B3? The opacity of that material, is it an incisal shade or is it a body or dentin shade? How thick is that increment? What's the filler and particle size in that material? And what kind of photoinitiators are in the material itself? And then there's always, sometime you might look at your light, you might look at your material and say, which directions do I want to follow? I think you're always best following the material instructions themselves. But what if the material instructions, as we've talked about, just aren't clear or complete? Where does that leave us? Well, we've got to follow our heart on this. So let's take a look at what happens, light performance over distance. One thing that we can control over that is how close we get the light to the restoration. And again, the light, the further it gets away from the restoration itself, the less energy that's going to get there. And these 4 lights on the right side, you can see the energy beam profile looks really good at 2 millimeters, and you start to see the irradiance of the light, the energy, the usable energy of that light getting less and less as you get further and further away from the tooth. And that makes common sense. The other thing is if we're using a light barrier, and especially an opaque one, this can further reduce the performance over distance. So be careful. We're going to talk about barriers in a moment as well. And then following that light performance over distance, again, the average light can lose as much as 10% of its intensity with every millimeter it comes away from the tooth or the restoration. So if you think about it, 5 millimeters away from the restoration, you could lose potentially 50% of that light intensity. That's why the collimation of the beam is very important to decrease the problem of distance. And the little graph shows the intensity of that light through various sized orifices or apertures over distances of 1 to 10 millimeters. And the picture below shows the hot spot. In the middle is producing over 6,000 milliwatts per centimeter squared. But then as the distance increase drops to under 500, as the distance increases, then the intensity of that light, the irradiance of that light, then drops to only about 500 milliwatts per centimeter squared. So this really shows the extreme variability of a light with a poor beam profile and poor collimation. So the distance from the tooth, when we cure a resin, the irradiance of the light is multiplied by the time of exposure and is reported as joules per square centimeter. So research has shown that a 2 millimeter increment of composite requires somewhere between 6 and 24 joules per square centimeter to polymerize it. Now, numerous studies have shown that the energy levels available to polymerize that resin will decrease as the tip moves away. And this will happen with some lights more than others. Does it happen with yours? That's going to be something you're going to want to find out. And potentially using a light with a higher irradiance might help, according to one study, but potentially more of that beam collimation may be the secret to giving you a little bit more flexibility moving away from the tooth. Aha, budget curing lights. Everybody loves a bargain, especially dentists, right? And yet at what cost? Some lights on the internet can range from as little as $25, and some that we can purchase through dental supply houses and dealers can go into the $2,000, $3,000, $4,000 range. The price isn't always an indicator of quality. I would say on internet sales, it's all about buyer beware, because you just don't know where the source of the LEDs are, what kind of chips are in there, the beam collimation, the beam profile. None of these can be verified if you're buying something over the internet. Now, there are some new ISO standards for dental curing lights that were just released in 2018, which help us a little bit. One states that we're going to limit the light output in the spectrum to no more than 4,000 milliwatts per centimeter squared. I certainly think you don't really need any light, for the most part, over 2,000 milliwatts per centimeter squared. And the light output should vary by no more than 20% of the manufacturer's stated output. So those are some guidelines that are going to help us in picking out lights. But again, I like to think about when we buy a light, maybe we want to buy it from a reputable source. Bargain lights can have odd spots too, and we can't verify that beam profile like we can if we buy from a reputable manufacturer. This is a little illustration. We all have a gas grill, and there's always a hot spot or two in the gas grill where you sear, and there's always that cooler spot where you kind of keep the hamburger or the steak going for a little bit while you're waiting to go to dinner. So again, the hot spots on the light are not a laughing matter, that's for sure. This is interesting, a recent study that examined the radiant power, spectral emission, and beam irradiance profiles and the ability of the light to sustain output values over a single charge cycle. It compared 3 LED lights from major manufacturer to 3 that they were able to purchase over the internet. And what they found with these budget lights, they showed fluctuating values of irradiance at the tip, extremely high outputs at the center of the tip, unable to maintain and sustain stable light energy outputs as the battery decreased its charge over time. And yet all the lights from the major manufacturers provided even output for at least 100 on-off cycles. So again, the idea of buying from a reputable source may be the key here when you talk about purchasing a curing light. Heat. Is heat a problem? I think it can be a problem for lots of reasons. Again, the surface temperature of that material conducts the heat that comes out, and every LED is going to produce some level of heat one way or the other. Some curing lights have the potential to increase that resin surface temperature to 80 degrees centigrade in just a few seconds, and pulpal temperatures can rise 5.5 degrees Celsius as well in just a very short period of time. Again, all LEDs are going to generate some level of heat. And I would say if you want to dissipate that heat or attenuate the heat issues at all, probably the easiest way to do that is either to wait 3 to 5 seconds between 10-second cycles of curing, or to simply use cool air from your syringe over your prep, whether you use it on a consistent basis over the entire time you're curing, or short bursts from time to time just to dissipate any potential heat buildup within the restoration. And yet if you look back at the science and the literature, there's really no documented pulpal death as a result of light curing in the literature. And yet we know that that heat can build up as a heat sink in that resin material, so why not take the extra step of using that cool air from your syringe? Light guides, they come in all shapes and sizes as well, and they can become damaged and contaminated with our use. I think disposable infection barriers can be very helpful and are recommended if you can at all use them. But you want to avoid certain barriers like opaque ones that can decrease the amount of energy coming out of that light tip by as much as 40%. And make sure that they fit properly, because even a poorly fitted light guide or a badly fitted light guide may be a negative. For instance, the light guides across the top are fixed light guides, and they can end up getting chipped, damaged, and you can get crud and gunk and everything else in all those nooks and crannies. And that's really not a very OSHA specific or barrier specific kind of problem. You really need to have some sort of a barrier to put over it. And if you put a light barrier on it, you want to do something that fits really, really snug, that creates a very tight surface on the face of the light tip. Something that fits loosely like this does is not going to give you the same beam profile and the same beam collimation, because this is going to distort the energy that comes out. Same thing with this seam in the middle like this. That seam is going to create a problem for the light energy coming out of that tip. You want to be able to pull that material tightly over the end of your light guide. And something as simple as your saran wrap or plastic wrap that you can buy at the grocery store makes an excellent, excellent disposable barrier and is totally clear. But maintenance and damage can happen no matter what. Lights get dropped, lights fall off the countertop, lights get bumped, chipped, et cetera, and the fiber optics can be damaged as a result of that. Autoclaving can damage the tips as well. And just, use and abuse and composite getting on the ends of those light guides and not being cleaned off can not only damage it, but it change the light profile, the beam profile, and collimation as well. Fixed light tips over time can get scratches, chips, have missing pieces on them. And again, the light body damage, things like being, taping your light together with duct tape. You've got dead head displays, corroded filters, broken reflectors, all sorts of things that also happens a lot in the halogen lights can sometimes happen to your LEDs as well. So let's talk about light spectrum for a minute. What do we want to know about what comes out of the tip of that light? And again, what we do know is that for light cured dentistry, that light spectrum is in the 400 to 500 nanometer range for the most part. Now, matching curing lights is very important and with your material, because although the chemistry and physics can be complex about there are some important things to be aware of if you're mixing and matching lights and the materials from different companies. All light materials are placed and cured in the patient's mouth include, camphorquinone, as we've talked about, the basic photo initiator CQ. It's a yellow compound. It's used in small amounts, which absorbs blue light to harden the composite. Now, if the composite is well cured, the CQ is pretty much all used up or bleached out during the photo initiation cycle, and there shouldn't be any, remaining yellowish color from the CQ. However, in the graph, we also see the bell curve of the single peak spectrum, which represents the output for a blue only LED curing light. The other curve is the CQ curve, which is simply what the material needs to harden. So in this particular graph, the two curves overlap each other fairly well and is nearly an ideal match, meaning that most of the CQ will be converted during the polymerization cycle. Now, if you're wondering about the broad spectrums a little bit, with some of the newer photo initiators out there, it's because they contain initiators that are outside of the blue spectrum, and they need violet light, such as in a 380 to 420 nanometer range, or ultraviolet light, some of them even below 380 nanometers. One in particular, TPO, is a white compound, and you can see in the graph that it has a single peak LED in the middle of the graph, but that does not overlap with this initiator at all. So we may be in a problem where it may not react at all with that particular photo initiator if you're using a single peak spectrum blue LED light. A broad spectrum LED light, or what's also known as a dual peak or a polywave, they're just different names for the same thing. We can see in the graph that additional smaller peak further to the left of the bigger blue peak is coming from a violet LED. Now, can you see why broad spectrum lights are necessary? Because the violet LED peak overlaps the TPO initiator. So we've got to have something that picks up a little bit of that TPO initiator if in fact we want to be 100% certain that we're going to get the proper cure. Finally, let's look at what happens with a broad spectrum light used on a blue only material. Now you can see the violet light is not well suited for curing the CQ. And there have been numerous papers and studies that have shown that the challenge of getting that violet light through these materials. And this is kind of reminiscent of the older days of light curing when UV lights were used and they found issues with depth of cure. So again, broad spectrum light is not as efficient on materials that only require blue, and your material may not need violet at all, but all materials do need some camphorquinone. And one light that's out there on the market now even allows you to turn off the violet component if you wish. So this is interesting too. I always like to look at different graphs and wavelengths, and let's just look at 4 different light types out here: a halogen plasma arc, a single peak LED, and a multi-peak LED. And as you can see, the older halogen and pack lights were more of a broad spectrum, where again the graphs kind of overlap each other and show that, again, you can pick up all of the light spectrum that you need. But these required filters, which could eventually break down or get damaged over time. The LED has a naturally narrow spectrum, so really no filters are needed. You don't have to screen out the rays that you don't need. And they're much more efficient. which is really why they've taken over the market over the last several years. And again, 95% of the restorative resin-based composites require only blue light. So what do your materials need? Well, let's take a look at that. So composites can vary significantly in the amount of curing energy required to polymerize them. We've talked about that. And this can occur between manufacturers or within the same product line, shades of composite, flowables versus body, et cetera, et cetera. And every composite has its own energy requirement to reach its full potential. This data is available for the composite from your composite manufacturer, and you want to be able to get this data, but it takes a while. If you want to go manufacturer to manufacturer and ask them for this data, this could be quite time consuming. But there's a much easier way to do it, and the one that I discovered a couple of years ago is called the check mark test from Blue Light Analytics. And MARC stands for Managing Accurate Resin Curing. And what happened here is it's actually currently, I believe, available through the 3M reps in the United States. Our 3M rep came out. He brought his laptop computer with his own software that was geared to this particular specific radiometer, and he asked me to gather up some of our curing lights that we use in our office. So I picked out 4 or 5 curing lights, brought them to Fred, to try out, and he determined from that, for instance, the light on the left side, the Smart Light Focus, had a radiance of 1179 milliwatts per centimeter squared, and the other light we were testing out that day had 1209 milliwatts per centimeter squared. That's great. I know what the irradiance is of my light, but it gets better because Fred also said, what composites are you going to use? And I said, well, I use A, B, C, D, F, G. And he said, fine, let's add them into the database. And so based on the data that was accumulated by Blue Light Analytics, they're able to take my light at my irradiance in my office with my curing lights that I use on a daily basis based on the shades that I use and create a report that tells me what my incremental depth of cure can be for how many seconds, both touching the restoration and 6 millimeters away from the restoration. So I created a guide for my office of how confidently we can cure our materials in our office with our lights. I found this to be fascinating, and what great data for us to have in our offices. This has now been moved to the next dimension. We're moving to the 21st century, and so Blue Light Analytics has made this now available to us to have in our offices on a daily basis. And the system is now called the checkup system. And again, an amazing instrument, an amazing tool to have at the tips of our fingers. The radiometer that you see at the bottom will allow you to take the curing lights in your office and get an average irradiance of your curing lights and store that data. And then based on the materials that you're using in your as composites in your office, you enter that into the data bank as well on either your iPhone or iPad or other device, and it creates literally a data card file, a recipe file, so to speak, where you now can take your materials with your lights and know instantaneously that I can cure with confidence 12 seconds, 8 seconds, depth of cure. I think it's data that is just immeasurable in our practice right now. Again, the sleek style, it's wireless Bluetooth operating, a couple of batteries as a power source, and it's so easy to use. We can update it. It's great because you've got an updated base that's constantly being updated by Blue Light Analytics, and we can update as we add a new light or remove a light from service. We add a new material, we simply add that to the database, and it immediately tells us with our lights that we are going to get a certain depth of cure in a certain number of seconds. So we talk about the cost of things. You know, there's always a return on an investment. What do we need to know about our lights and whatnot? And I would say if you're talking about what it costs to do a filling, the takeaway point here on this particular graph is to look at how little a curing light costs you every day in every filling that you use. And if you bought a curing light and basically threw it away after 4 years, the big part of your cost is not the curing light itself, but it's probably the most important thing that you use at the chair. So knowing how your curing light works with your materials, I think is paramount to great patient outcomes. And if you decide, well, I'll just simply overcure, I'll cure another 40 seconds, another 50 seconds on light curing. Yes, you can do that to a point, but you can also create heat, as we've talked about as well. And let's talk about the financial aspect of overcuring. What's the cost-benefit ratio of that, or what is the return on your investment? It's not a good one, because you're going to use an additional, let's say, 20 seconds per cure, 5 patients a day, 50 weeks per year. You lose another 5+ hours just in that additional curing time. So wouldn't it be important to us to know that I don't have to do that to get a good cure, that I can use my curing light in my office with my materials and get an accurate and confident cure every time? So again, my mantra is your lights, your materials, your curing times, all in one place. I think it's just curing with confidence. I think it's an important tool to have in our practices, and we greatly welcome it at our office. Light curing, we talked a lot about composites. It's not just about composites. Over 50% of the procedures we do every day involve the use of a curing light, and more of them are using to cure and spot tack, various things, whether it's orthodontic brackets or our crown and bridge restorations or ceramic veneers. And one study interestingly just started to come out about use of zirconia crowns, and how one reported zirconia type really limited the amount of curing energy that was able to get in and start the photo initiation of the cement that was used, and resulted in a lower degree of conversion. My thought on this is that we're going to see more and more data come out of this, and I think this is a topic for our next webinar, is how do we measure those light outcomes with some of our other indirect materials that we're using. So stay tuned for that one. So when should we consider light replacement? Is there a minimum output that you should consider? Well, again, the data tells us that recommends a minimum of 400 milliwatts per centimeter squared to cure at 2 millimeters of material with a halogen light. A value less than 233 milliwatts per centimeter squared should just not be used. An average of radiance of 300 milliwatts could be probably your bottom line, again, for a 0.5 millimeter measurement of composite. But again, these are old data with halogens. I think the newer recommendations we have to look at with the LEDs are, we want a light probably no less than 500 milliwatts per centimeter squared, and really no more than 2,000 milliwatts, and exposure times of at least 10 seconds. You can vary that. I like to say that 1,000 milliwatts is my base to work from. The lights do decline rapidly, some more than others, and you want to make sure you're keeping that accurate data. That's why, again, the checkup system may be important to your practice. Other types of testing, just not possible to distinguish the proper curing from things like disc testing. And the most common reasons cited for replacing composite restoration are the loss of the material itself from fracture and secondary caries. So if we're properly light curing, that's going to absolutely improve our outcomes for our patients. When should we consider replacement of our light? When we have damaged tips, we see that our light manufacturer may or may not have given us accurate data. Understand your light tip and accurate active light curing tip area of the tip. Obtain and record an accurate measurement for your light when new and periodically when it's new, and periodically monitor over time. That one I can't emphasize enough. I think that's very important, to monitor your lights on a regular basis, and that's what, again, the checkup can do for us. Now, when you see degradation has occurred, when it's dropped below a threshold that you're comfortable with, 1,750 milliwatts, it's time to replace the light. You want to understand how your light performs at clinical distances, and how much, again, irradiance you're losing at 1 millimeter away, 5 millimeters away, 1 centimeter away. Make sure that your light delivers an output that satisfies all the requirements stated in the materials that you're using. And how often should you test those lights? I'd say, how long do you want to go without identifying a problem? Test them every day if that makes you feel better. Test them every week, I'd say, is probably your minimum. Otherwise, you get something that you really don't want to have happen. So it's time to buy a new curing light. As we kind of wrap up our seminar, what are we going to look for? Budget lights online could end up being an expensive experience, because you might end up under-curing, over-curing, and damaging, the overall patient outcomes in the long run. Keep it simple. Keep a light between 1,000 and 1,500 milliwatts. A low-profile light tip will enable easier access to those tight areas, like the buckle of number 15. A relatively even light source output for relatively even cure. That goes back to quality beam profile. Consider how you're going to keep the infection control high. Do I need to use a sleeve or a barrier, and that effect of that barrier on light performance? Understanding how that light performance at that distance will require sometimes a longer curing time for deeper posterior restorations of certain shades. Understand those basic light curing material requirements if they're provided, such as the minimum and maximum light output, the curing time and the increment thickness for various shades, the light type required. And if you're unsure, always reach out to your manufacturer. They're there to be a resource for you as well. And then confirm that the light that you're planning to purchase can satisfy all your material requirements and really comes from what I would call a legitimate source, someone that you can trust to give you a quality product. So what are my final takeaway points? Know the key parameters you're looking for to give you excellent light curing protocol. I want to have you keep in mind the role that we play and our assistants play at the chair with proper light curing positioning of that tip. Continue to look to sources that you can trust to purchase those curing lights and for questions regarding the materials you're using and how to properly utilize the curing light you've purchased. And utilizing current technology to help you quantify your light curing technique by pairing your light with your composite to maximize successful patient outcomes using something like the checkup from Blue Light Analytics, because you really don't want to take light curing lightly. Otherwise, it could end up being a very sad day for us in our offices. So I want to thank you for spending the last hour with me. We have time to take questions, and I certainly welcome any of those questions this evening. Any questions we don't have time to get to tonight, I would certainly feel free to have you contact me at my email address, ddssmile@aol.com. So with that, thank you for your time, and I open up the floor to any questions we may have from our viewers. Oh, great. Great question comes in. What kind of lights do you use in your practice? Well, I tend to want to say, for number one, I use only LED lights from good sourced manufacturers. I use LED lights. I've got a couple of smart light focuses. I have blue phase style from Ivoclar. I've got Velo Grand. I've got a Fusion 5 from Dentlight. I've got a couple of 3M lights. So I've had an opportunity to try and utilize many, many different lights in our practice. I've found all the lights really over the last couple of years that we've gotten from major reputable manufacturers to be excellent lights and have been very helpful in our practice. So I would say, again, go to the sources that you trust. If there's a company that you utilize their composite material, take a look at their light specifically and look for the parameters that we've discussed tonight. I think that's important to check on all these parameters. They should be able to supply the data on beam profile, beam collimation, and I really can't emphasize enough the importance and the impact that the checkmark test had on me 3 years ago when I took it through our 3M rep, and my eyes were open as to how I thought our curing lights were working well. I had tested them, but really to have that data, that database knowledge, and now with the ability to have it through the checkup system, I think it really goes a long way toward giving us the confidence of cure at the chair. What radiometer do I use to get the most accurate output? Prior to this, I was using the Dematron radiometer in our office, but now that we have the Blue Light Analytics checkup system, that is the definitive source to me for the most accurate reading of my curing lights. What adhesive system do I use? Oh, that's a great question to ask. I use a lot of them. I've had a great opportunity to work with a lot of manufacturing companies over a long period of time. I've probably tried literally dozens and dozens, if not maybe hundreds of materials and adhesive systems over time, from 4th and 5th generation detonant bonding agents to the ones that we're using now, the universals. Currently, right now, I like to use, I'm using Surefill, I'm using Clearfill SE, Clearfill Protect, Adhese Universal, Prime and Bond Elect Universal, Tokiyama Bond Force. Those are probably the ones I use most of the time in my practice on a daily basis. Are flowable resins adequate for class 2 restorations? I would say that there are some amazing flowable resins today that either function, first of all, as an underlayment or a initial layer and then top capped with a body composite. The reason I like flowable resins in general is because they adapt to our preparations very, very well and don't tend to leave voids and little gaps that we sometimes can get with a paste composite. Can they hold up to the stresses as an independent source? There are some out there. Boco has one that you can utilize as a flowable resin and tends to be able to fill up the entire preparation 4 to 5 millimeters deep and shows good wear characteristics and good flexural strength properties similar to a paste composite. So yes, there are composites out there. I would not hesitate to use a flowable resin in the appropriate way. What are your thoughts on the dual cure bulk composites like Bulk EZ? That's a great question to ask, and we do talk about that quite a bit sometimes. The question lies, I think, most of the time when people revert back to a dual cure or a self-cure material, they're really concerned about their light getting into that deepest part of the box and properly, photo initiating the composite, the reaction. And I would say to that, that's certainly not a problem to use those materials. I think it's more of a factor of time and efficiency at the chair for me. I feel that the comfort level I have with my materials and my lights allows me to cure in those bulk and semi-bulk fill increments much more readily. And so I have the confidence that I don't feel personally that I have to use dual cure or self-cure bulk fill materials. But certainly that is a good avenue for someone to utilize. I would not discourage you to look at that if that's a comfort level for you. What would you find is the average life of the curing lights that you use? Well, that's a really interesting question. And I would say that the curing lights that I've been using now, I have seen over a period of time, as we've checked them both with the Dematron radiometer and most recently using the checkup system, is that they will degrade slowly over time. Now, the old halogen lights, you could check with a radiometer and you might get 900 milliwatts per centimeter squared one day, and an hour later or 2 hours later, after a little bit of use, it might have dropped 30 to 40%, and it would still be very bright, and you wouldn't know it unless you checked it with a radiometer. The LEDs tend to degrade a lot slower. And again, I would have to say that the lights that I'm using today, some of them have been in service about 4 to 5 years now, and they still are maintaining a level that I'm comfortable with. So I go back to, can you buy a curing light from a reputable manufacturer that does their homework? I think that's really the key when you look at a light curing. And again, if you look at the dollars and cents of purchasing a light, if you get a light that gives you 4 to 5 years of use, as we looked at in that schematic earlier on, I think that's a win for us. That's pennies per day to utilize a quality light. Do you feel that the high intensity lights with the fast cures, like a 3-second cure with a sapphire plasma arc light, cause excessive shrinkage and or post-op sensitivity? That's a great question as well. Thank you for sending that in to us. That's still a bit of a controversial topic and subject, but I will say that the sapphire plasma arc lights and lights like that give you a good broad spectrum. So you're going to cure over a nice blue wavelength and some of the materials outside of the blue spectrum. I think a buildup of heat can be a problem, but again, the published papers that are out there really don't show a direct link between the heat and post-op sensitivity or pulpal problems with the use of these lights. The 3-second cure, again, I think you've got to look at pairing the light with the material that you're using. And I think the data on that is a tough one. I think if you're using a light like a sapphire plasma light, I've talked to numerous dentists who use it on a daily basis, and they're not reporting anecdotally any clinical problems with their patients. They're not having post-op sensitivity that they can directly link to the light source. So I would have to say that the jury may still be out from the research on that, but anecdotally, I think you could feel very comfortable using the plasma arc light as long as you pair it up properly with the material that you're going to use to restore the tooth. If there are no other questions, I think I appreciate those tonight. I appreciate everybody tuning in. And again, feel free to reach out to me at my email, ddssmile@aol.com, to keep in touch with any future questions or concerns you have regarding lights, composites. Always happy to be a resource for you. So thank you for your time again this evening.